Okay, David, tell us a little bit about the Alaskan Health Partnership and what partners are there with your partnership?
Well, the Alaska Federal Healthcare Partnership is a true partnering of the federal healthcare activities in the state of Alaska. And it includes the Alaska Veterans Agency Health Service, the Alaska Native the Alaska Native and Tribal Healthcare Consortium, the Alaska Native Medical Center, the Department of Defense, inclusive of the Army, the Air Force, and Navy, Marine Corps, and also the U.S. Coast Guard. All are members of the partnership, and that the partnering is essentially to cooperate and graduate, or to share capabilities and capacities to provide the very best health care closest to home.
Wow. So you've had this telehealth program that you've implemented with the partnership, and how long have you been doing telehealth?
Well, the partnership has been doing telehealth since the early 1990s, and the partnership's actually been in being for well before 1940s. So the whole idea of being able to cooperate has long embedded in the philosophy of healthcare in Alaska. But the program that I'm running is home telehealth monitoring, and it was started in the summer of 2007 as an initiative to help provide better health care at a lower cost for the people in the partnership, the beneficiaries of the partnership.
Okay. Are you mainly targeting older patients with acute care conditions or chronic conditions?
Well, our program was started in order to help elders stay at home longer, to stay in their villages. If you can appreciate, a village is built upon an elder structure where the leadership of the village and the education of the grandchildren, so to speak, are the responsibility of the elders, then the loss of an elder in a village is quite traumatic. So the intent of the program was started to help elders stay in the home. But it's designed for chronic disease management, long-term care, and as such, it's just as equally viable for childhood obesity, childhood diabetes, as it is for end-of-life care or chronic care of an individual who's just been diagnosed as diabetic.
Well, you're saying it's viable for those conditions. Do you have any statistics, any outcomes that you can share with us?
Oh, sure. We're, as a matter of fact, we're going to be briefing that in about 45 minutes.
Okay.
But
I'm way ahead of you.
We have a lot of outcomes data for every single patient in the program. We're showing long-term improvement for those patients who actually send their data in and participate in the program. You can have one of our home monitors, but if you don't use it, that is, you take your vital signs and send them in and be an active partner in your own health care, then you're not going to get better. But for everyone who is actually sending data or being compliant in the program, they're showing actual, very distinct improvements or better outcomes. Let's just take the standard of care for diabetics improvement basically is to hold them at their current condition without them getting worse. Well, what we're seeing is that they're actually getting better. Their glucose levels are being reduced. We've got communities where over the 2 years of a program in that particular community, their average glucose level has been dropped to 40 milligrams per deciliter, which is an average for a community, so say a community of 39 people. It's amazing to have an average glucose drop for 40 milligrams per deciliter. And we've correlated that with their A1Cs and shown an actual decrease in the A1C values, average A1C values for that whole community. And so the benefits are dramatic, and indicate that we're not just holding them in their condition; they're actually getting better.
Wow, that sounds fantastic. You mentioned compliance. How about those who aren't compliant? Are you giving them some incentives to comply, or how are you increasing compliance with this program?
Compliance is a difficult issue for all home telehealth monitoring programs throughout the country, and ours isn't any different. We have looked at how you choose patients in the first place, and our number one criteria is to find patients that will actually send their data, and we rely upon the doctors to do that determination. The next thing is to encourage them through feedback, and that is what gets monitored gets managed. It's an important concept that if you're actually managing something, there's an internal competitiveness in each one of us to do better. And so if you're actually seeing the data and you're watching it yourself, then you're going to get better. It's just like if you were on a weight scale, and every morning you got on the weight scale and you said, okay, well, But if you took that same weight and you wrote it down, and you could actually see your progress towards weight reduction, you're actually going to have a faster ability to get to your desired weight. And it's the same kind of thing. If you're watching the data and you're monitoring and managing, you're going to be involved, and that means you're going to be better able to take care of it. But the data also allows for what we call intelligent intervention, which means that the medical professionals looking at the data are going to be able to look at the trends and be able to predict if you need to have a change in medication or a change in your instructions for how you're taking care of yourself, and be able to get that to you. And we provide a service which is the home monitoring is looked at 24 hours a day, 7 days a week, 365 days a year. So if somebody is not feeling well, for instance, in the middle of the night, they can send their data. Somebody's going to actually see it. They're going to get in touch with them, and they're going to get their help right now.
So it's not passive monitoring.
No, it is actually active
monitoring. Okay. Wow.
So that makes our program very much different than a lot of other programs. In addition to that, we're doing chronic disease management. That is, if you're on the monitor and you're sending data, you get to keep that monitor and continue sending that data.
You know, that sounds great, but what's this program costing you, and how is it being paid for?
Currently, the program is being paid for by direct federal funding, and of course this is for federal beneficiaries, so it's appropriate for that to occur. The intent is to move it into self-sustainment, and we are working on a modeling and business plans for self-sustainment, and we believe a combination of health agency fee and also reimbursement for services will help in that. Our current cost per patient per month is about $550 per patient per month, which is fairly high. But we expect that if we can get to about 1,500 patients online, that we can actually get that to below $200 per patient per month. And then with reimbursement, carve away about 3/4 of that, and then the user fees would be about $50 per patient per month. And we think that's a self-sustainable value that the health agencies or the individual would be willing to bear.
Well, you know, we're all hoping that's the case. I believe payers have to step up to the plate, but sharing this type of information with payers is going to be crucial for you to get those reimbursements.
Oh, absolutely. And data is absolutely the number one thing that everybody wants. So we are collecting outcomes data, and we're also collecting cost data, and we'll be briefing both of those at our presentation. So we'll be able to show that not only are patients getting better with home telehealth monitoring, but we're actually able to save money doing it. Now, the question is the cost savings sufficient enough to pay for the program in and of itself? And one would think that would be the case, but the cost breakout doesn't allow for the savings to be spread in the right places. So, for instance, if a doctor is not being reimbursed for the time that they're spent on computer monitoring their online patients, right, and they are going to get paid for their office visits, they're going to do office visits.
Sure.
Okay.
Sure.
So even though they could be able to do maybe 10, 30 patients in the same 15 minutes that they would be able to look at one patient, they are going to get paid for the one patient but not the 30
Not the 30
patients.
patients, that's right.
Yeah.
That's right.
So we have to have some additional help in terms of getting the right language in to help the payers with making the determination that paying for 30 telehealth visits
Right.
is a whole lot less expensive
Than the
than
one.
paying for one visit or 30 patients over a
Exactly.
long period of time. So.
Well, thank you, David. I appreciate your time. Sounds like you got a great program. I congratulate you on the collaboration. I think that's probably the best collaborative that I've heard of from a state yet. And it sounds like you got everybody participating and everybody working on the same page in telehealth. So congratulations to you and your program, and I wish you continued success, and thank you for talking with SearchHealthIT.com.
Well, I appreciate that, and I need to recognize the leaders of the partnership, the executives, as well as the executive director, Sam Johnson,
Okay.
who is my supervisor.
Okay, good.
All right.
Thank you, Sam.
Thank you, sir.